cameras. A very good afternoon to respected dignitaries, governing body member of RAV, Director RAV Dr. Vandana Siroha ma'am, Gurujans, I welcome you all in another intellectual session of Gyan Ganga webinar series. I, Dr. Saraswati S., on behalf of RAV, welcome you all for today's session. On the onset, we would also like to express our heartfelt gratitude and welcome our mentors who have always been there to guide, motivate, and encourage us for sustenance of this series. Respected Vaidya Shri Devendra Trikunaji, President of GBRAV, respected Vaidya Shri Rajesh Kotecha Sir, Secretary, Ministry of Ayush, respected Dr. Vandana Siroha Ma'am, Director RAV. It is my privilege to extend a special welcome to the new batch joining us today. We are truly pleased to have you as a part of our Gyan Ganga webinar series. Today's guest speaker is Dr. Sarika A.K. Ma'am, Assistant Professor, PNNM Ayurveda College, Kerala, who has joined us today in the 249th episode of this knowledge voyage. Let us begin this session by seeking the blessings of Lord Dhanvantri. Om Dhanvantraya Namaha. Now, I would like to introduce today's expert, Dr. Sarika A.K. Ma'am, who is going to throw light on the topic clinical spectrum of anorectal masses, critical review, and integrated management. Dr. Sarika A.K. is an assistant professor in Shalya Tantra with strong expertise in teaching, clinical practice, and research. She holds a MS in Shalya Tantra from Government Ayurveda Medical College, Bangalore, with additional certifications in emergency medicines, Madhumeh Chikitsa, and clinical cosmetology. She has received the Best Researcher Award in 2024 and contributed multiple research publications and presentations. With extensive experience across reputed Ayurveda institutions, she has developed specialized expertise in Sharasutra therapy and the management of conditions such as hemorrhoids, fistula, varicose vein, and rectal prolapse. Now, I would like to invite ma'am to proceed with the lecture.
Thank you, Saraswati. Thank you for the warm introduction. Am I audible?
अभी थोड़ा ऊपर और करें मैडम.
Okay. So, first of all, I would like to thank the organizers for giving me such a great opportunity to present in this platform. And with all my due respect to my all gurus and teachers, I will start the topic. And today's point of discussion or the topic we are going to discuss is about the clinical spectrum of anorectal masses, a critical review and integrated management.
Excuse me, ma'am, can you please turn on your camera?
One second.
Yes.
It is so is it
तो
visible
visual
now?
आगे ऐप हो गया.
No, ma'am.
Can I rejoin? Can I leave and rejoin again?
No, ma'am. It's okay, ma'am. You can continue, ma'am.
अभी तुम जोड़ा नहीं किया, तुम अभी जोड़ नहीं किया, इसे दिखाएं जरा.
The slides are not visible for me right now. Can I rejoin again?
Yes, ma'am. Yes, ma'am.
शिवम से पूछो, शिवम से. इससे नहीं होता. ऐसा
मेरे पास गूगल मीट थी, उस पे तो डालते नहीं है ये.
अग्नि नमस्कार।
Namaskar, namaskar.
नमस्कार।
कौन बोलो? बोलता हूँ नमस्कार नमस्कार जी। बंद दवाई बंद दवाई।
Hello. Is it audible now?
It is audible now.
Is it full screen?
No, ma'am.
Not full screen. Audible but not full screen.
Is it okay to continue with that?
इसके में नहीं खुल रहा, इसके में दोनों बढ़ जाओ।
Oh, yes, ma'am. You continue.
Okay.
फोटो आ जाएगी क्या?
Thank you.
Except the presenter, please everyone keep your cameras and mic off.
Yeah.
तुम्हें आया था ऐसे? ऐसा थोड़ी 4G तुम्हारा नहीं गया, तो सब में आता है भाई।
Shall I start?
Yes, ma'am. Start, ma'am.
Yeah, okay. So today's topic of discussion is clinical spectrum of anorectal masses, a critical review and integrated management. So when it comes to the anorectal disease, it is one among those topics which always patients hesitate to talk about. But as clinicians, we cannot definitely sit without talking about it. Okay, so just imagine a situation, a patient comes to your clinic with complaints of mass per annum. So the question arises here is whether it's a case of simple hemorrhoid or whether it's a case something which is serious about. So that we have to analyze. So I think I hope by the end of today's discussion, you would be able to appreciate it, in which condition you are supposed to give a conservative management and in which area you need to give a serious outlook. Okay, so today's contents are differential diagnosis, red flags, diagnosis, and the Ayurvedic management. So before moving into the details of individual disease, we will just simply see the surgical anatomy of anorectal canal, and this picture demonstrates you the important landmarks of anorectal canal. So here you can see the rectum and the anal margin, and in between there are serrated margins. Okay, so these structures, there is two different surgical canal, surgical anal canal and anatomical anal canal. Surgical anal canal means it starts from the anorectal ring. This is a band-like structure which is lying above this dentate line, and the surgical line, surgical anal canal starts from here and ends at the anal margin. Whereas anatomical anal canal is, it starts from this dentate line, the serrated margin, and ends at the anal verge. And there are few more important structures like internal sphincter, which is involuntary in action, and these are the external sphincters, which are voluntary in action. So this is very, very important because when you make a surgical incision, these voluntary fibers, if it has been cut, the incontinence will happen. Okay, so you have to be very careful while manipulating with this or while doing any interventions with this anorectal canal. Let's move on to the core aspect of today's studies. It is the clinical toolbox.
Madam,
Pardon?
hello. Your
ma'am.
slides are not moving.
Ma'am, slide is
Not
moving,
visible.
Ma'am, not moving. It is
Important
still on the
anatomy is
second
over.
slide.
Okay.
Second slide is not seen. You explained everything.
Okay, okay. Let me check, sir. 1 second.
Ma'am, now it is fine, ma'am.
Okay, thank you. So the first part of analyzing an anorectal mass is history taking. So why the history taking is important? So I can give you an example. Few months back, around a 55-year-old person came to my clinic complaining of painful anorectal mass. So I was thinking about, as a physician, I was supposed to take a physical examination, and I inquired about the complaints and all initially. And then I was about to conduct a physical examination before getting in detail about the history. So while asking about the history in detail, the patient told me that he had undergone a kidney transplant 5 years ago. And then he said he is on immunosuppressant medication. So before going into the physical examination, I got a first clue regarding something serious is underlying. So when I inquired about the family history, while mentioning about the family members and all, he explained that his elder sister got a type of skin cancer in her early age. So at that point, I got the second clue. And thirdly, when I inquired about the personal details, the patient told he is experiencing some kind of unintentional weight loss. So that was the end of the story. I performed a physical examination, but there was a discolored mass which was tender, and then I could have concluded it as a thrombosed external hemorrhoid if I didn't have taken this proper history. So once when I took the history, when I got the clues after the physical examination to confirm the diagnosis, I sent the patient for biopsy and it was confirmed as an anal carcinoma. So that is the importance of history. So history taking both all the personal history, surgical history, family history, treatment history, everything is important in this aspect. So next comes to the perianal examination. In perianal examination, we have to see if there is any visible scars or visible mass or some external opening or any kind of discoloration like that features you have to examine. So while doing the perianal examination, it is always better to go for a part preparation and enema. Sometimes there is a chance of missing some external opening if the patient is hairy, because it has happened for me. So I always prefer to go for the perianal examination after proper cleaning of the part. So while examining perianal examination, you can see different kinds of masses. It could be some simple sentinel tack or some internal external hemorrhoid, or sometimes there could be some anal swellings like perianal abscess and all. So that has to be noticed and it should be documented. So next part is digital rectal examination. In digital rectal examination, you are manipulating with Buddha Marma, that is one among the 19 Sadhyo Pranahara Marma. So while doing the digital rectal examination, you should be very careful. You are not supposed to poke your finger into the anal canal. With the pulp of your finger, you have to examine the anal canal. So while before doing that, if the patient is complaining of acute pain or acute condition, then it is contraindicated. Once the inflammation or the pain subsides, you can easily go for a digital rectal examination. Otherwise, if the patient is okay with the manipulation, then you can slowly introduce your finger from the anterior anal verge and slide it down, and slowly you can introduce it into the anal canal. So initially, it is always better to go for a digital examination with your little finger, and then you can try with index finger. So while examining, you have to see if there is any palpable masses or if there is any depression like in internal opening and all. It could be seen or it could be felt as a depression in the mucosa. And sometimes in hypertrophied papillae, there will be some swelling which slips under your finger. So that those types of features can be assessed through this digital rectal examination. While inserting the finger, the first and foremost thing you have to notice is regarding the spasm. Initially, whenever you do an anorectal examination, the patient, how much ever you explain also, the patient will be scared of the examination. So initially, it is normal to have a constriction or tightness at the anal sphincters. But usually, if it is not so painful condition, that spasm will relieve after some times. So that is called as voluntary spasm. But in acute painful conditions, even if you keep your finger for some time, it stays tight only. So that kind of spasm is called as involuntary spasm. So the next important aspect is proctoscopy. So there you are directly visualizing the lesions inside the anal canal. So here using the proctoscope, here also while using the proctoscope, it should be lubricated well, and then the perianal region should be lubricated well prior to the examination, and then slowly introduce the blunt end of this proctoscope, and then you have to move slightly forward and downward. And then once it reaches the anal canal, you can slowly withdraw this obturator and see the lesions inside. So sometimes the patient will be having a bleeding pile. Sometimes there will be some internal opening, or sometimes there would be hypertrophied papillae, or some change in the mucosal texture. Everything can be visualized through the proctoscopy. So that is the first stage of analysis. In these examinations and history taking and all, if you could find anything which is marked as red flag, so in that condition, you can go for the advanced investigations like sigmoidoscopy or colonoscopy, biopsy, and imaging techniques like MRI and CT and all. Otherwise, before going for any surgical procedures, it is usual to go for a blood test. The fitness of blood fitness is always necessary prior to the procedure. So always a simple blood test can help you assess different situations. Like if the patient is having a chronic hemorrhoidal blood loss, that also can be diagnosed through the simple blood test. And the more serious conditions like malignancy can be detected through the tumor markers like CAE and all. So that is the importance of blood test here. So once the red flag sign is identified, it is always better to send them for a colonoscopy or sigmoidoscopy to have a look at the proximal bowels. And it is also indicated that after a year, 40 years, if a male, especially male, not only male, but it is commonly seen in male patients. So that is why I specified the male gender. Otherwise, if the person is above 40 years and if he is experiencing some constitutional symptoms along with this bleeding, painless bleeding and all, to rule out the chance of malignancy, it is always good to go for a colonoscopy. And if there's something suspicious, if you find out, then the biopsy is the gold standard investigation for confirmation. So once the biopsy is done, definite histopathological confirmation will be achieved. So you can conclude the diagnosis. And the imaging, the importance of imaging, that is MRI and CT. MRI usually in case of fistula and all, to identify the track of fistula and all, we suggest MRI fistulogram. CT is mainly used for the tumor staging. So moving on to the next point, it is a structural approach to differential diagnosis. So we have already seen that there are different kinds of masses which can be presented in the anorectal region. So if we classify it based on its structural difference, it can be mentioned under different headings. The first and foremost thing is vascular. So vascular, it is already known that hemorrhoid comes under this category because it is hemorrhoid occurs when there is a engorgement or dilatation of the inferior rectal venous plexus occurs. It can be presented as the hemorrhoid. So hemorrhoid comes under the category of vascular lesion, and then comes the mechanical lesions. Prolapse of rectum can be taken under this category because continuous straining and loosening of the sphincters can lead to this kind of presentation and complete prolapse of the rectal mucosa. So prolapse of rectum can be counted under this mechanical lesions. And then comes the inflammatory and infectious lesions. There we can include the perianal abscess and the acute and chronic fissures. There will be an inflammatory reaction in the initial stage of acute fissure, and continuous recurrence of this inflammation will lead to a fibrosis of the edges of the anal fissure, and it can later present as a chronic fissure. So it can be included under this category. And then it is viral or hyperplastic. So many conditions like condyloma acuminata and hypertrophic papillae, all that comes under this category. And definitely at the end, it is malignant lesions and adenomatous polyps and all considered as the benign growth in the anorectal region. So here we are seeing individual diseases one by one. We are going to see in detail about that. One is hemorrhoid. So in this picture, you can see two different lesions. One is starting inside the anal canal and one is lying outside the anal verge. So in this picture, as we see, the internal hemorrhoids, the one which is lying inside the anal canal, is called as internal hemorrhoids. And you can see the origin is from the dental margins, whereas the external hemorrhoid lies completely outside the anal verge. So the difference while examining these hemorrhoids, how you can make out an internal and external hemorrhoid, definitely it is based on this position. But there sometimes what happens is there will be a combination of internal external hemorrhoid. and there will be a external hemorrhoid. So in that context, while examining, if you are seeing a skin component and a mucosal component, it can be concluded as a internal-external hemorrhoid. And if it is completely covered by skin, it is external hemorrhoid. Whereas internal hemorrhoids are completely covered by mucosal membrane. So this is how you make out or how you differentiate the internal and external hemorrhoid. So the second picture shows you a inflamed swollen hemorrhoid. So this condition is called as thrombosed hemorrhoid, one of the most severely painful condition of anorectal region which presents with a mass. So here you can see a bluish or purplish discoloration. So this kind of presentation can occur in person who is undergoing a sedentary, who is following a sedentary lifestyle and who is straining too much during defecation and all. Due to that continuous pressure, there will be venous congestion and that can be presented as a thrombosed hemorrhoid. So in Ayurveda also you can see this particular condition while explaining the Chikitsa aspect. Vagbhata Acharya has told a particular condition where he says avartamanam raktam uchridam katinam. So this can be correlated to the features of thrombosed hemorrhoid and the management as given specifically. So that we will be discussing when we come to the management aspect. So this is in general, how you can manage or how you can give a conservative management to the hemorrhoids. The initial or the prime objective of our treatment is always to alleviate the symptoms, to give the to reduce the discomfort to the patients. So there are different methods. The first and foremost thing is dietary modification and lifestyle changes. So while dietary modification, if you are taking in consideration, the most important thing is you should ask the patient to include lot of fibrous food into the diet. It is fibrous food if you simply say that they may not understand. So you have to give a list of vegetables and fruits which can be taken as a rich source of fiber. And then definitely adequate hydration. So how it will affect the hemorrhoid management is it softens the stool and easy passage of the bowel can happen because of this adequate hydration. And there also the specifying the quantity of fluid to be taken is very, very important. And it is always it is said that for each 25 kg you have to take 1 liter of water. So based on that you have to calculate the amount of water to be calculated. And then there is topical applications to relax the anal sphincters and to reduce the muscle spasm. You can give different relaxants like some gel, or in Ayurveda if you are using, there are Jatyadi ointment or Jatyadi gridam, anything can be applied and to relieve the spasm in the anal sphincters. And then definitely you have to make the passage of the bowel easier. So for that purpose, you can make use of some laxatives like Avipatikari Churna or Triphala Churna. Anything can be used, or Anuloma DS, anything can be make use of. And finally, the most important tool of anorectal condition to reduce the pain and to reduce the discomfort of the patient is always sitz bath. It is dipping the perianal region in a fluid-filled tub. So here the fluid media can be, sometimes you can use a plain warm water, and if it is available, if the medicines are available, medicated guatas like Panchavalkala guata or Triphala guata, anything can be used for sitz bath. And time also you have to specify, it should not exceed 20 minutes, and the warmth should be checked prior to the procedure. If the patient is sitting in a more hot water, it can even cause burning. So that should be checked before using. So then comes the important surgical interventions. There are many methods are available, but I have, as per my clinical experience, I have witnessed a few of this, among them, and I have included those methods in this slides. The first and foremost thing is rubber band ligation. The advantage of rubber band ligation is you can do this procedure in any degree hemorrhoids. So I forgot to mention one point when I explained the internal hemorrhoids. Based on the intensity or the clinical presentation, the internal hemorrhoids are again divided into 4 degrees: first, second, third, and fourth degree. In first and second degree, the internal hemorrhoids will be lying inside. Completely in first degree, it will be completely inside the anal canal, but it will cause some discomfort. While in second degree, during defecation, it comes out and it's spontaneously reduced by itself. And in third degree, during defecation, it comes out, but it doesn't reduce by itself. You have to digitally reposition the hemorrhoidal mass into the anal canal. But while straining, it comes out again. And in fourth degree, it will be permanently outside, and you have surgery as the ultimate option. But whereas in Ayurveda, we have different options available that we'll be discussing later. So these surgical interventions can be discussed on the base of degree of internal hemorrhoids. So as I told you, rubber band ligation can be used in any degree hemorrhoids. Like even in a third degree hemorrhoid also, you can simply use this method. And here you are using a Barron's ligator, a particular instrument called Barron's ligator, and using that, it is a gun-like instrument. And with that, you are applying very small sized rubber bands into the base of the hemorrhoidal mass. So what you are doing here is, the mechanism of action here is, you are producing a ischemic necrosis. So the blood supply to the distal aspect of the hemorrhoid is lost, and it will fall off as it is. So it may take more than 7 to 10 days, but within 2 to 3 days, the patient's discomfort will be relieved. So he can wait for the hemorrhoid to fall off later. Okay, the second method is sclerotherapy. Here we are using a sclerosing agent we are injecting a sclerosing agent into the hemorrhoidal mass. It will cause the fibrosis, and because of this fibrosis, there will be shrinkage of the hemorrhoidal mass will occur. And then it is infrared coagulation. Here you are using light therapy or infrared energy to coagulate. And then because of this coagulation, there will be size reduction in the hemorrhoids. And the ultimate option is surgical removal only. Final option is surgical removal only. It is most effectively seen in severely recurrent cases of hemorrhoids and large hemorrhoids. This is the best option. And when the other methods are have been failed, in that condition also, you can choose hemorrhoidectomy as the treatment modality. And these are the few advanced managements they are following in modern science. And here they are identifying the distal roots of the artery, internal venous plexus, and then that should be ligated, and it is using a Doppler guided proctoscope it is done. So these are the advanced technology they are using in the management of hemorrhoids. And now we will move on to the management in Ayurveda. So when Acharya Sushruta and Acharya Vagbhata explained about this Arsho Chikitsa, they have given Chaturvida Arshasam Sadhanobhaya. 4 methods have been mentioned. Based on the stage of the disease, you can make use of 4 instruments to cure 4 treatment modalities to cure the Arshas. So he says, Acharya Sushruta says, Tadyada Veshajam Charo Agni Shastramidi Tatra Tirakala Jatani Alpadoshalinga Ubadravani Veshaja Sadhyani Mrudu Prasrada Avagadhani Uchritani Sharena Karkasha Stira Prutu Kadinani Agnina Tanumulani Uchridani Kledavanticha Shastrena. So whenever a hemorrhoid is diagnosed, there is no rush to go for a surgery. You can always opt for an alternate medicine, and there you can initially you can try the management with some medications, internal medications. So in the first third line, Acharya gives the indication for Beshaja Sadhya Arshas. He says, Achira Kala Jatani, if it is recently originated, and Alpa Dosha Linga Ubadravani, if it is manifesting with very mild symptoms, you can always try with Beshajas. And then comes the indication for Kshara, Mrudu Prasrata, Avagadhani, Uchridani, Ksharena. He says if it is Mrudu and if it is broad and Avagada and elevated, then in those situations, you can try with Kshara. And then it is Agni. If it is hard and tender mass, then you can go for Agni Karma. And then Tanumulani, Uchridani, Kledavanticha Shastrena. Finally, if the hemorrhoidal mass is Tanumula and Uchrida and Kleda, more of Kleda, then you can go for Shastra Karma. So this is one of the case. We had one of the case where we had conducted Kshara Karma in our OP. This was diagnosed as a primary internal hemorrhoid at 3 o'clock position, and the patient was taken for Kshara Karma, and we had applied Kshara over the hemorrhoidal mass, and the second picture is the outcome of the treatment. So here, while explaining Sharakarma, Sushruta Acharya also has given some specific position and specific instructions. So when we see the slogas in that, Acharya says, Snigdam Ushnam Alpamannam Dravaprayam Bhuktavantaha. So in the context of Agriopaharaniya Adhyaya, Acharya again explained Arsha Chikitsa. Prior to the surgical procedure of Arsha Chikitsa, patient should be kept empty stomach. And in the context of Sharakarma, Acharya says Laghu Bhuktavantam. So why is this controversy? Because Acharya might have mentioned this because the patient should be able to withstand the pain of this surgery or this Kshara Karma. For that purpose, he should have advised to give some light diet or easily digestible diet. And some says it's only for Mukharshas, Acharya told to stay empty stomach. So that controversy is happening, but I think the first option would be the better to consider here. So while doing the Kshara Karma also, Acharya told some specific position. He says the upper part of the body should be kept in the, he says that it should be placed in the lap of the Paricharaga and Kinchit Unnata Katigam. Kinchit Unnata Katigam means Pratyaditya Gudam Kinchit Unnata Katigam. So this, if you just scrutinize these terminologies, you can just see that the Acharya may be indicating the patient has to be taken in the lithotomy position. And Pratyaditya Guda means the Guda should face the east direction so that lighting will be proper. And then it is Kinchit Unnata Kadigam. As we do surgical procedures, we always take the patients in lithotomy position only. That is the most convenient posture to perform the surgical procedures. So once the patient is taken in lithotomy position, then we have to slowly introduce the instrument into the anal canal. Arsho Yantra is introduced after proper lubrication of the perianal region, and the lubrication of the instrument also done properly, and it is slowly inserted into the anal canal. And then you have to identify the hemorrhoidal mass, the location you have to identify. Once the mass is identified, in the normal mucosa, to protect the normal mucosa from burning, you have to keep a few cotton balls inside the anal canal, and then you have to apply the kshara with the help of Darvi, Urchaga or Shalaka. That is the indication from our instruction from our Samhita. Any of these instruments can be used to apply the kshara over the hemorrhoidal mass. And the time, how long you are supposed to keep the kshara over the hemorrhoid. Acharya says Vakshata Matra. So clinically, we used to keep it for 50 seconds, not more than that. By then, the Samyak Dagda Lakshana can be seen. And Samyak Dagda Lakshanas, when he explained, Acharya says Pakku Jambava Pratikasham. It will be around some purple color. In general, Acharya, even though he has explained Pakku Jambava Pratikasham in general, but in the Vyakhyanam, if you go there, you can see different colors as per the predominance of the doshas. If it is Pitta dosha, Acharya says it is Mayura Kanda Varna, Bringa Mayura Kanda Varna. So some kind of bluish tinge can be seen. And if it is Kafaja Harshas, Brihadi Pushpa Varna. So it could be some purple color. So a tinge of purple or black or bluish color can be seen based on the predominance of dosha. And he also gives indications if there are multiple hemorrhoids are present, how you are supposed to go for the Kshara Karma. Acharya says, if there are multiple hemorrhoids, first you have to do Kshara Karma on the right one, and then the left one should be treated, and then posterior one, and then finally anterior one. And while doing this Kshara Karma, you have to maintain a gap of 7 days. So Saptaratrat Karmam Purvita. So these are the references you will get from this Sushruta Samhita regarding this hemorrhoids. And in my clinical practice, I found it is very useful, Kshara Karma, if you are applying the same method in the OT. So coming to the Abhyantara Aushadha Chikitsa. So this concept is taken from Ashtanga Hridaya, Vakbhatacharya's Ashtanga Hridaya. There, as we have seen, the hemorrhoid presentation can be in 2 different ways. One is Shushka Arshas and another one is Shravi Arshas. Shushka Arshas, as we know, it is Kapha Vada predominant. So the treatment line should aim as Ushna Kapha Vadagna Chikitsa we are supposed to apply here. And for that, different Bahya Upakramas have been explained, like Sneha Parishega and Abhyanga with Kasisadi Taila, and different types of Sveda, etc. has been explained. So coming to the Kasisadi Taila, it is found very helpful in the reduction of hemorrhoidal mass. So in sloka itself, Acharya says, Sharavat Padaye Drudam, and it is Shara Karmakara. So what result you are going to get through the Shara Karma? A similar result you can achieve through this Kasisadi Taila application also. And while explaining Dravasveda, Sveta, we can make use of Dravasveda in the form of Avagaha Sveda or Parishega. And here you can make use of Trifala Kvata or Panchavalkala Kvata for the Dravasveda purpose. And Pindasveda, when I discuss about this Pindasveda, there is a particular formation what we use in our OP. Palandu is minced. Palandu is taken and it is minced and it is sought in Grida, and then it is made into a small potali and it is applied. With that warm potali, it is applied over the hemorrhoidal mass, especially in the thrombosed hemorrhoid, it is found very effective. And there are many more Bahya Upakramas have been told, Dupana, Budavarti, Leba, and Abhyanga. So there are different formulations also have been given as per this Dupana Karma. For Dupana Karma, we are using a special yoga in our OPD. I would like to share that yoga with you because it is very effectful in inflammatory conditions like thrombosed hemorrhoid. We can take the Palandu Duk and it can be mixed with Tila and Sarshaba, and all these are burned together and the fumes are applied to the hemorrhoidal mass, and there will be definitely pain reduction and the inflammatory signs will be reduced. So this is the concept. This is the interesting concept I told you when I explained the thrombosed hemorrhoid. There Acharya says avartamanam rektam uchridam and katinam. So if there is a blood clot and if it is hard and tender, you can always opt for a rektamokshana, and there are two ways in which we can perform this rektamokshana, either through the jalauga or you can perform a shastra karma to remove the avartamana rekta. So if in my clinical practice what I experienced is always better to go for the shastra karma that will give immediate relief to the patient. Instead, if you are going for jalauga, it should be applied on every third day and it will within 3 to 4 days the inflammatory signs will be reduced and the patient will have this patient will be comfortable by then. So next is about the Aushadha Chikitsa of Arshas. As we have seen, there are two different types, Shushka Arshas and Shravi Arshas. In Shushka Arshas itself, there are two different presentations. One is Arshas with Binna Shakrit and another one is Arshas with Gada Shakrit. In Arshas with Binna Shakrit, we are supposed to use a formulation which is Kapha Vadagna, Grahi and Deepana. So if you scrutinize this, analyze this features, you can get a particular yoga which can be exclusively used in this particular context. That is Takra, which is Kapha Vatagna, Grahi and having Deepana action. So that can be extensively used in Shushkarshas with Binna Shakrit. And in different conditions also it can be used as Anupana, and different yogas have been explained in this context. And Acharya says in one particular condition, Gudashwayetu, when there is Shushka Arshas, if it is associated with Binna Shakrit, and then there is associated complaints like Gudashwayetu, Gudashaula and Mandakni, there you can make use of any of the churnas, Shat churnas, which is explained under the context of Gulma, that you can just name it as Vaishanara Churna, Hingu Vajati Churna or Hingu Ashtaka Churna. Anything can be taken along with Takra as Anupana. That will reduce the symptoms. And then Guda Haritagi has been given. Guda Haritagi daily, 2 Guda Haritagi should be taken along with Takra. That also will help relieving the Binna Shakrit and all the other symptoms. And then Takra Tarpana with different drugs have been mentioned to reduce the symptoms. Then it is Shushka Arshas with Ghada Varcha Chikitsa. There is Vibandha. To relieve that symptom, you have to use Vata Varcha Anulomaga Chikitsa. Here, instead of Buddha Haridagi, you can make use of Gomutra Haridagi. The detailed preparation of Gomutra Haridagi is also explained under the context of Gada Varcha Chikitsa, and it should be taken along with Madhu as Anupana. And then there is mentioning regarding this Pipali Vardhamana Rasayana and different yogas like Dusparshagadi Kashaya and different Arishta Kalpanas like Abhayarishta, Dandyarishta, Duralabharishta, and Pipalyadi Anuvasana Thailam. So if you analyze these yogas, Dusparshagati Kashaya, in my clinical experience, what I experienced is in conditions when there is, it is found more useful in Sravi type of arshas. If there is bleeding pile, it is found more effective. And if you are using Chirivilyadi Kashayam in this Shushka arshas also, if the patient is having some gastritis symptoms, it can aggravate or it can worsen the condition. In that condition also, you can make use of this Dusparshagadi Kashayam. And coming to the Arishta Kalpanas, Abhayarishta acts as Deepana and Rukshana. So, if the Gada Varchas, Shushka Arshas is predominant of Kapha dosha, there you can make use of Abhayarishta, whereas Dandyarishta and Duralabharishta is Vatanulomana, and Dandyarishta especially it is Mala Anulomaga and Vatanulomaga, whereas Duralabharishta is Vatanulomaga and it is Shita Virya in action. So you can, if there is a Pitta association, if you could observe a Pitta association from the symptoms, you can easily make use of this Dusparshagadi and Duralabharishtam. That will help you to pacify the symptoms. And then definitely the important yoga which is used in the context extensively is Pipalyadi Anuvasana Taila. This is Snigdha and Ushna. And if there is excessive Rukshatam, this kind of Anuvasana Vastis can be adopted. And if there is excessive Mala Sanchaya, then Niruha Vasti is advised. If there is Udavarta, Atyartam, Rukshana, Vibandha and all, Anuvasana Taila is indicated. Otherwise, it is Niruha Vasti. Then coming to the Sravi Arsha Chikitsa, when we analyze the symptoms, there is Vatanibandha Lakshanas and Kafanibandha Lakshanas. It is nothing but the symptoms have been classified based on the predominance of dosha that you can go through. And based on this predominance, you can fix the treatment. If the Rektarshas is associated with Vata, there you have to follow the treatment protocol as Shita and Snigdha Chikitsa. If it is Rektarshas and Kapha Anubandha, there you have to use Shita and Ruksha Chikitsa. And then Acharya explained about Tikta Rasa Prayoga in Sravi Arsha Chikitsa, and how the Tikta Rasa helps us. Acharya says it is Doshanam Pajanartham, Vahni Sandukshanartham, and Rakta Sangrahanartham. So these are the objective of using Tiktarasa Prayoga, and different yogas have been explained under this context. Kudaja Avaloha, Kudaja Avaleha, and then Navanita Prayoga along with Tila, etc. can be applied for Sravi Arshas. And Acharya has given Ekamulya Dravya also in the context. He says Balladaga is best drug in Shushka Arshas, and Vatsaga can be considered as the best in Sravi Arshas, and Takra can be made use of in all types of Arshas. And there are some specific conditions have been explained due to the time limit. The allotted time is very limited, so I may not be able to explain everything in detail, but I'll try to cover the maximum of content. So this is one particular condition where Stambhana is mentioned. Usually Stambhana is contraindicated since it is causing so many complications. If we are flowing recta is abruptly stopped, that can lead to different complications. But if the rogi is Pittolbana and Garma Kala, if it is summer season and all, the Stambhana Chikitsa has to be followed. It is indicated in this particular context. So that has to be remembered. So this is regarding the Arsho Chikitsa. And now moving on to the next anorectal condition where it can be presented as a mass per annum. So here it is anal fissure we are taking in consideration, and you can see there are different masses. Okay, so the peculiar feature of anal fissure is it produces excruciating pain to the patient. So it is explained as shards of glass pain during defecation, and the pain lasts long after the defecation also. And the specialty in bleeding is that it will be presented as a blood streak during the defecation, blood streak along with the stool. So this is the presentation of acute anal fissure. But once there is recurrence of this anal fissure, and there will be inflammatory reaction occurring continuously, and because of this continuous inflammatory reaction, the edges of the wound will be fibrosed. Then it becomes a chronic fissure. So there it can be present with three features. It can be presented with deep ulcer, and then hypertrophied anal papillae and sentinel tag. Due to these features will occur as a result of repeat cut over the initial wound. So you can see this fibrosed edges, and this is sentinel tag at the posterior end of this anal fissure edge. You can see a skin tag like structure. So that is called as skin sentinel piles. And in the anterior aspect, this will be inside the anal canal. While doing the digital rectal examination, you can feel a mass sometimes which slips under your finger. So that is hypertrophic anal papillae. So these are the chronic fissure triad. So when it comes to the Ayurvedic aspect, it is explained as parikartika. This is not mentioned as a separate disease, but in the context of Basti, it is considered as one of the Basti Vyapat. Both in Charaka Samhita and Sushruta Samhita, you can get the reference for parikartika in the Basti Vyapat context. In Charaka Samhita Siddhisthana, sixth chapter, you will get the reference for parikartika. It says Gude Chedanavat Vedana. So the special feature of anal fissure is it produces cutting type of pain. And there will be Vata Pragopa and Vibandha and Daha. And the treatment mentioned here is Neha, Mrudu Virejana, Basti and Vata Pitta Shamaga Chikitsa has to be applied. And then in Sushruta Chikitsa Sthana, you will get the reference for parikartika in the Basti Netra Vyapat context. There also Acharya mentions that it is due to Vata Prakopa and Vibandha will be the associated complaint, and the presenting complaint will be Kartanavat Vedana Gude. Again, it is a cutting type of pain Acharya is explaining, and the treatments explained, treatment modalities explained here is Snehana, Pichudharana, Avagaha Sweta, Madura and Snigdha Dravyas, and it is considered as a Sadhyovrana. So it can be treated as Sadhyakshadavat Achari. It can be treated as a Sadhyovrana later. So in my clinical practice, what I do is initially to reduce the inflammatory reaction, I used to give some mild, not matravasti, but I call it as Thaila Purana with the 20 ml to 30 ml of Jatyadi Thaila, or based on the dominance of symptoms, I will decide the oil. So if it is Pitta predominant, I will use Yashti Madhu Thaila, or if it is Vada Pradhana, then I prefer to choose Jatyadi Thaila or Jatyadi Krita, and then it is administered using a blunt rubber catheter. I used to administer 20 ml or 30 ml of Thaila into the anal canal, and this within 2 to 3 days, the inflammatory signs will be reduced and patient will have comfort. And then I will try for a manual anal dilatation for 5 to 10 minutes under local anesthesia. I used to perform a manual anal dilatation with the smallest sized anal dilator. And then once the dilatation is done, I will let the wound heal for 7 days with some external applications and sitz bath. And then after 7 days, I'll advise the patient. I used to advise the patient to do the anal dilatation with the help of anal dilator, which is apt for his sphincter. I used to choose and ask him to continue that for 21 days. So that by then I used to get good result in this condition. So I just mentioned that particular treatment. So this is another anorectal condition where it can be presented with a mass per annum. So this is condyloma acuminata. This was a successfully treated case in our OP in PNNM Cheruthuruthi. So here also there was a cauliflower-like mass in the anal region. So initially the patient was not ready for surgery. So he came to our OPD, and then we initially we tried with Ksharakharma. And Ksharakharma, after Ksharakharma, there was a reduction in the symptoms, in the size of the mass. But after some time, this got flared up. So we couldn't try for another sitting. So again, what we did was a transfixation of the pedicle structure had been done multiple masses have been selected and transfixation had been done. And after a period of 2 to 3 months, patient was completely relieved and the mass was completely fallen off. This was a successful case treated in our OPD. So I would like to mention that here. So that was not Shara Sutra we used. It was a plain thread which was applied or smeared with Haridra Churna was used for transfixation. And the risk factor for this particular case was there was bleeding. So it was very difficult to manage that also, but still we tried with transfixation and we got good result. So if we consider different types of arshas, you can see the reference like Kadamba Pushpa, Tundigeri, Nadi Mukula, Suji Mukagradini. So what I think is this anal fissure and this condyloma acuminata and all, you can classify it under the Vadaja arshas because there will be severe pain and the mass which looks similar to this Kadamba Pushpa. The middle one is Kadamba Pushpa. So it can be taken as a Vadaja arshas, and this line of treatment also can be applied here. So some Sneha Prayoga will be helpful in such conditions. So that may help in this situation. So next is Bagandhara Pidaga or perianal abscess. It is said that in Abagandhara, there is reference that Apakwe Pidaga, Pakwetu Bagandharam. So it is an inflammatory condition. There, the patient will be presenting with severe pain in the perianal region with a angry looking swelling in the perianal region. So all the abscess features like rubor, calor, dolor, and functionalacia, all that will be present during the presentation along with fever and chills. It can be presented. So here the management goes like based on its avastha, you have to choose the treatment. If it is in the initial phase of formation, you can try with some labas, external labas like some Yashtimadu leba can be applied or Dashanga leba can be used to reduce the swelling and reduce the pain. But here in our OPD, we are trying different yogas for leba. I would like to mention few of them. One is with Guduchi Patra and butter mixed together and it is applied over the abscess, and sometimes curd can be applied, and sometimes rice flour also used as a leba, and that will produce the suppuration. The purpose of applying leba is either to reduce the swelling or to produce the suppuration. In some cases, it will produce a suppuration, it will burst open by itself. So in this way, you can give the comfort to the patient. So if it is in the Pakku Avastha, definitely the treatment is Vedana only. Vedana, while explaining the Agryopaharaniya Adhyaya Shastra Karma, Pradhana Karma, Acharya has explained in detail about the Vedana Karma. There, Acharya has introduced the concept of Shastrapada and how you are supposed to put incision, and leaving all the Sira, Snayu, Sandhi, Marma, Asti, you have to choose a particular site and then incision has to be done. And if the swelling is large, you have to put 2 incisions. Similarly, in case of gluteal abscess and all, we are using cruciate incision. With 1 incision, you may not be able to get access into the abscess cavity. So you have to put a cruciate incision, a cross-like incision, and through that central opening, you have to expand the abscess cavity, and then you are using the doing the draining. So this can be applied in the Vedana also. So that is IND procedure. So here also what I do is I always prefer to go for a incision and drainage in the Pakku Avastha of abscess. There I will use under all aseptic precaution. The patient will be taken into lithotomy position, and then using scalpel, an incision is put in the most dependent part of the abscess, and with this opening through the incision, a blunt artery forceps is inserted, and the locules of the abscess cavity is broken and it is cleaned with antiseptic solution, and it is packed with Jatyadi Thailam or some Yashtimadu Thailam can be used for dressing. Okay, so this is how I perform IND in my OPDs. Then it is, once it is opened, it should be considered as a Vrana, and then Shodhana and Robana Chikitsa should be followed as well. So some people, they follow is what once the draining is done, they will try for a probing and they can find out a track in the same sitting itself. And if there is a track found, then you can put a thread. A simple thread will be enough to drain the abscess cavity so that it will not progress to a Bagandhara. So this can also be adopted. So this is another condition where the disease can be presented with a mass per annum. It is explained under the context of Kshudra Roga in Sushruta Chikitsa, Sushruta Samhita. And Acharya says, Pravahana Atisarabhyam Nirgachadi Gudam Bahihi Ruksha Durbala Dehasya Tam Gudabramsham Adished. So here it is especially mentioned in patients who are Ruksha and Durbala. If they are adopted to continuous training during defecation, this kind of mass appears. And here in the treatment also, Acharya says, Swinnam Snehabhyaktam Praveshayet. The area should be lubricated well and Svedana should be performed and it should be inserted into the anal canal. And reposition, after the repositioning, the Gofana Bandha should be applied with the Madhya Chidra. And then Acharya has explained a particular yoga, which is Mushiga Taila. In Ashtanga Hridaya, it says that it is Unduru Tailam. Andhra Varchita Mushika is taken and the Kwata is prepared out of Mahat Panchamulam. And with this, you are preparing the Tailam that can be used in the management of Gudabramsha in the form of Pana and Abhyanga. And this, the case was one successfully treated case in our OPD. The patient was suffering since 20 years. And when he came with this prolapse, we were not sure whether we would be able to cure this, but we have performed Kshara Karma in this. And this is also done under local anesthesia only. Kshara was applied over the mucosal layer of this prolapse, and then it was washed off with Amla Rasa Dravya, and then it was repositioned into the anal canal, and Bandha, Gofana Bandhana was done, and it was continuously done for 7 days. And then we had given a Matravasti of Unduru Taila along with Pipalyadi Anuvasana Taila for the initial 1 week. And then later we switched to Dhanvantara Tailam plus Unduru Tailam. So this patient got complete relief and he is healthy and living a good life now. So I would like to mention that here. So the another condition, which I have to mention, if I'm not mentioning it here, it will be an injustice to this condition, but I'm not going in detail with the treatment of this particular condition, because it is always better to, if it is found malignant or if there is any red flag sign is present, it is always better to refer to the expert. So I don't prefer to treat such conditions, but still there are 3 different presentations of anal cell carcinoma. One is squamous cell carcinoma, another one is basal carcinoma, and then another one is adenocarcinoma. Among these 3, squamous cell carcinoma is the most commonly seen carcinoma in the anal region, and it is HPV related and highly risk factors for an immunosuppressant person. He is likely to develop this squamous cell carcinoma. And then there will be clinical presentations like chronic non-healing ulcer. If there is a permanent hemorrhoid symptoms, usually in hemorrhoid, the symptoms peaks and after some days it will reduce. So if that relieving of symptom is not happening, then you should be suspicious. And if there is any indurated mass, like if the anorectal mass is adhered to the underlying structures, you can suspect whether it is a malignant condition. And definitely the appearance of the mass will be irregular and it will look like a cauliflower. And bleed on touch is very, very important feature, because patient will be saying a painless bleeding. When he come to our clinic, he most probably he will be saying that he is having a piles complaint and it is painless bleeding. So he'll be relieved it is painless, but it is not that. So you have to examine that physically. Without a physical examination, without a proctoscopic examination or digital rectal examination, a diagnosis of an anorectal case is not complete. So these are the red flag signs so this here how you are supposed to screen the conditions and how you are supposed to choose the treatment. Everything is given in this flyer. So I'm not going in detail with all that. Next is the diagnostic algorithm, how you are supposed to screen a patient. Initially, we have seen many common anorectal complaints like pain, bleeding, and discharge, prolapse, everything has been seen. And as per the clinical manifestation, you have to do a thorough visual inspection, and then digital rectal examination has to be performed, and then proctoscopy is need to be performed. And then once in this examinations, if you found something suspicious, then you have to send it for the advanced investigations like endoscopic evaluation, like sigmoidoscopy or colonoscopy. And further, if something suspicious find out, then biopsy is the option, and then the confirmation regarding the lesion will be achieved. And then if it is if there is no red flag, then you can go for the conservative management as we have discussed in the slides. So if it is thrombosed external hemorrhoids, initially you can try with some inflammatory, anti-inflammatory topical applicants, and then you can go for a shastrakarma or sometimes rectamokshana. And if it is acute anal fissure, as per the presentation, you can choose the treatment. So this is a comparative summary table of our anorectal conditions. So where I have taken into consideration a few clinical manifestations like bleeding, pain, discharge, and mass. In different condition, how it will be presenting. In anal pressure, in anal fissure, the bleeding will be like a streaks of blood on the stools. Whereas in hemorrhoids, it appears as a splash in the pan. So before passing the bowel, there will be a splash of blood in the pan. So this will be the presentation in hemorrhoids. And in anorectal abscess, it will be mixed with the blood will be mixed with pus. And then rectal prolapse, it will be bright red. It will it will be associated with the protrusion. And in cancer, there will be dark or red type of dark red bleeding can be seen along with mucus or stools. When it comes to the pain, the concept of pain, it is excruciating, cutting type of pain can be seen in anal fissure, whereas in hemorrhoids, it usually occurs as a painful condition, painless condition. It is found painful only in thrombosed hemorrhoid. And anorectal abscess, as we have discussed, this is one of the most severe painful condition in the anorectal area. And then it is rectal prolapse. Usually a dull ache will be present, and most of the time patient will be presenting with a discomfort and a heaviness in the anal region. And in malignant conditions, there also the patient will have a tight obstructive type of feeling and some kind of pressure coming down or some kind of discomfort in the anal region. So next is discharge. Usually in anal fissure, there won't be any discharge. It is if there is hemorrhoid association, there could be some mucus discharge as the presentation. And in anorectal abscess, it is always a pus coming out through the anal area. And in rectal prolapse, it is always mixed with mucus, and sometimes it will be associated with blood also. Whereas in malignancy, it will be blood or mucus mixed discharge can be seen. It will be appearing as a red currant jelly. And coming to the mass, it will be in anal fissure, it will be presenting as a sentinel pile along with sometimes there could be a hypertrophied papilla also. In hemorrhoids, the mass will be soft and squishy, and it will be sometimes tender also. If it is thrombosed, it will be tender also. In anorectal abscess, it is told that it is an angry looking swelling can be seen. Red inflamed type of swelling can be seen in the perianal region. And in rectal prolapse, a concentric layers over the prolapsed mass can be seen. So this will confirm the diagnosis. And in cancer, there will be irregular surface over the mass, and it will be hard, and there will be bleed on touch. So this is the summary or comparative analysis of anorectal features. So how you can improve the quality of life of the patient in different conditions. So I will suggest you to follow the fiber fluid frictionless triad. It is nothing but ask the patient to take the fiber rich source of food. So this will act as a cushion, and fluid will soften the stool, and the laxatives, it acts as a laxative, and it will easily it will help the patient to pass the bowel easily. And frictionless continuous movement or physical activity help the patient to keep the gut healthy and peristaltic movement will be proper. So ask the patient to follow this fiber, fluid, frictionless triad for the conservative management. And then pain management is the important thing. You can advise a sitz bath in many of the condition. It will be very effectively used. And the next part is psychological impact of chronic anorectal disease. So here also you have to convince the patient. You have to explain to the patient how serious is the condition and how light is the condition, whether they can sit and relax or whether they have to take serious action against this complaint. That you have to very clearly you have to introduce and advise the patient to take the further follow-up, and the fear should be reduced, and the panic regarding the symptoms also has to be relieved through proper counseling, and that also will help to some extent. So the key takeaway is preventive and therapeutic role of dinacharya has to be used well in this context, because proper sleep and proper ahara vidhi, if the person is following a proper ahara vidhi and abhyanga, everything which is explained under the context of dinacharya, if the person is following all this, he can lead a very healthy life. And don't assume every bleeding mass is a hemorrhoid. Every painless bleeding mass cannot be concluded as a hemorrhoid unless you have gone for a advanced investigations and for the checkup and all. So you cannot conclude it as a simple bleeding pile mass. And then obviously the patient has to be advised with the dietary instructions, which type of food he is supposed to take. You just tell them that eat healthy foods, eat fiber rich food. Patient will be confused which type of food is healthy. So that has to be specified and advise the patient in a clear way. And then it is always important that early diagnosis is more important than the management. So if you could early diagnose the case early, you can sometimes save the life of a patient. So early diagnosis is always important. So by the sloga, I will end up my presentation. It says the importance of Agni in the context of Ashra Chikitsa and Ashtanga Hridaya. Acharya says, if the Agni is proper, even if there is dosha dusha samurchana, the disease does not manifest. But if the Agni is deranged, there can occur different types of elements. So with this, I conclude my presentation. Thank you.
If anyone is having any doubt, they can ask now.
शारिका जी बहुत बहुत धन्यवाद, बहुत अच्छा आपका प्रेजेंटेशन रहा।
Thank you,
रक्ताश पर
sir. Thank you so much.
बहुत ही सुंदर विश्लेषण किया है आपने। राष्ट्रीय विद्यापीठ का आपका बहुत बहुत बधाई और धन्यवाद आपको। बहुत ही सुंदर विश्लेषण किया है आपने।
Extremely thankful to you, sir. Thank you so much.
लेकिन ये बताइए, यदि ब्लीडिंग ज्यादा होती है मैडम तो क्या देते हैं हम लोग? यदि ब्लीडिंग और जलन दोनों होती है तो रस चिकित्सा में बताइए, क्योंकि हमारे पास तो पेशेंट आते हैं, अपोलो है, मैक्स है, यहाँ से वापसी आते हैं, तो अगर वो क्षार सूत्र न करावे तो क्या दिया जा सकता है?
Saraswati, can you please translate? I didn't get the question.
Ma'am, he's asking that the patients that come to them, they don't prefer Sharakarma. So what rasa medicines, rasa aushadhis can be given in such cases?
Rasa Aushadhis, once Kshara Karma is done, there will be complete falling off of the hemorrhoidal mass. Hemorrhoidal mass, once it is fallen off, there won't be any symptoms. So after that, you don't have to give any medication for maintaining that state, but you can instead advise the patient to follow some daily routine. Ask them to continue with fiber-rich food and proper water intake, and the defecation should be proper without straining. So if he is maintaining this regimen for a longer period, he can stay healthy in that condition. And regarding your question, sir, I'm not using much of rasa aushadhis, so I don't think my suggestion will be helpful for you in this context. What I suggest is I always suggest my patient to take Dusparshagati Kashayam along with Durala Bharishta and then some Triphala Gugulu and Gandhaga Rasayana for 1 week, and later that can be stopped and they can continue the Dusparshagati Kashaya for 1 more month and then they will stop it. That was the usual prescription I do after Kshara Karma.
If some patient burning and itching in piles,
Ah.
much burning, itching and pain with bleeding, with
Okay, sir.
bleeding.
Ah.
So what are you giving some medicine?
In such a situation, it is topical applications would be better. The patient will be getting relief by applying Yashti Madhu Thaila as a Matravasti or in the form of Thaila Purana. You can administer very minimal quantity. As I told you, it is only 20 ml of Thaila we are infiltrating into the anal canal. If you are using any Pitta Shamaga Aushadhis like Yashti Madhu and all, it will definitely help the patient to give relief from the symptoms. In our OPD, we are using a special yoga called Manjishta Sariba Lepa. There we are preparing a Grita-like ointment like for medication with the this contents, Manjishta and Sariba, and we are asking the patients to apply this over that area, and that used to give relief to the patients.
Okay, thank you, madam.
This is hello. This is Dr. Dattatreya Rao from Tirupati. Hello.
Sir, I didn't get you, sir.
Yeah. Very good, Dr. Sarika. Congratulations. You have covered many of the aspects of the anorectal problems. And
Thank you, sir.
Your suggestions for the day-to-day practice also, it's very good.
Thank you so much.
Actually, already it was very much big and comprehensive. So there are many other points also we can add to this whole. And instead, disease-wise, if you have gone, that would be better. That means hemorrhoids and fissure and fistula and other disease. If the presentation is very good and very wrong also, but some of the things we may miss when we are comprehensively going with every disorder. That is one of my just a suggestion. But
Yes, sir. I will definitely
your
take in
presentation
consideration.
part was very nice, and you have tried to cover everything. And
Thank you, sir.
my and a few of my suggestions regarding where you have to work for that. So
Okay, sir.
generally, people feel that hemorrhoids and whatever it is that anorectal disorders, they are very much recurrent in nature.
Yes, sir.
So,
Yes, sir. Definitely.
And first question when the patient comes to you, he will ask, "Sir, if you treat, will it disappear or it will go forever or will it come back?" That will be the main problem of the.
Yeah, that is the actual challenge we are facing. Yes, sir.
Yeah, that also you search over this, why it is again coming back, or is there any problem with our treatment, or is the nature of the disease like that, or that also we have to focus, and you have to tell to our youngsters to understand the various principles for
Yes,
this.
sir. Definitely.
Then
Definitely.
another, there is a vast research is going on Sharasutra and its application in the other form of diseases. So that
Yes,
also
sir.
we should cover, like in hemorrhoids, in pilonidal sinuses, in certain, some people, they even claim that they are applying for fissure in ano also. But
Yes,
that
yes.
all those things also, we should actually search over it and see the authenticity of these practices. So anyhow, thank you very much. And you have covered much of the subject in
Thank you,
one
sir.
single seminar. I should congratulate. And thank you,
Thank you, sir.
RAV,
Thank you so
for
much.
arranging such a important topic and important lecture. And that too by a youngster who is practicing, is practically very much active. Thank you very much.
Hello, madam. May I speak, please? Madam,
Krishna ji.
one aspect of the anorectal region mass, I think it is the rectal polyp also comes under this mass lesions
sir.
in the. But you never uttered this word, the rectal polyp and all that. So especially because I am a comorbidity, so
Yes.
just I am sharing my experience. It is the rectal polyp was like this one grape. the coming out of the anal region and having a
Yes,
very
sir.
good
I missed that one,
the
and
this
I will.
and very young child. Simply just I tied the with the thread and removed, but he was very happy instantly. There was no issue.
Okay, sir.
So your experience, being you are a specialist, so we want to share know about your experience about rectal polyp, especially in pediatric cases.
So if I'm actually saying I have never come across such a case in my clinical practice, so I don't have much experience in that field, but definitely I have heard of such cases, people treating with Ksharasutra and all. This is one real incident I have experienced. Thank you for sharing that here, sir.
One more, because it is especially your lecture is useful for youngsters who are the RAV students. So
Yes,
you
sir.
said the another the axis, the
Yes, sir.
incision should be taken the most dependent part.
Yes, sir.
The dependent part of which position? The in lithotomy position. If you take
No,
in
that
lithotomy position,
most,
most
what I
dependent part
understood,
becomes, and when he is standing, and it becomes the upper part, isn't it?
it is actually from my understanding, what I understood is the most dependent part means the most what gravitational dependent part. If you are putting an incision, that should completely drain the abscess. So it should be in the lowermost aspect or in the lateral aspect, sir. So my from my understanding, I got the concept like that.
That
It is
means
not
it
that
must
face
be
of the
in standing
abscess.
position. The most the most more close to the gravity force is the in standing position, that becomes the lower part. But in lithotomy position, that will be something different.
Yes, sir.
Usually it is done in lithotomy position, isn't it?
Yes, sir. Yes, sir.
So in that case, a dependent part becomes when he stands, and that will be a different position. So
So usually we perform this IND in lithotomy position only. So the most dependent part will be in the lowermost lateral aspect of the abscess. So if you put an incision in that particular site, I have experienced that complete draining of the pus is happening if I am putting an incision at that particular site. So I think that will be the most dependent part. That would be the definition for most dependent part, sir. The area where by putting incision, you have to drain the complete pus easily.
okay.
Good afternoon, ma'am.
Good afternoon.
Myself, Dr. Rajesh Kumar. Ma'am, please tell about differentiation, complete rectal prolapse and partial rectal prolapse, and treatment also, ma'am.
Okay, so the rectal prolapse, as per textual reference, what you get is the size of the prolapsed mass is more than 3 to 3.45 centimeter. It can be 3.75 centimeter. It can be considered as a complete prolapse. The partial prolapse will be smaller in size. And this concentric layers, different layers, circular layers can be seen around the complete prolapse.
And ma'am, treatment?
Treatment usually in complete prolapse and all, what I used to do is the Kshara Karma only. What I shared in the last slide is like Kshara Karma performed in a complete prolapse, and the patient got complete relief. Complete reduction of the mass was happened after the Kshara Karma. Maybe because of that, the fibrosis induced after this Kshara Karma, that would have helped to stay that in Thier's operation and all, you are fixing that prolapsed mass in that anal mucosa. That is what you are doing in the operative procedures also. But while doing Kshara Karma also, after the application, you are washing it off and then you are repositioning it. Okay. And then you are inducing a kind of fibrosis over the mucosal area, and this will adhere. This will make the prolapsed mass to stick to the anal mucosa. This will help the patient to completely get relief from the symptoms. You can even make use of cautery instead of Kshara. So
Ma'am,
prior to the Kshara Karma procedure, I had given multiple pricks with needle, 25 gauge needle. I have made multiple pricks on the anal mucosa, and then the Kshara was applied, and then it was cleaned and it was repositioned inside.
Okay, ma'am. Thank you, ma'am.
Thank you, ma'am. Now we conclude the session. On behalf of organizing committee, I would like to thank Dr. Sarika A.K. ma'am for delivering such insightful lecture. I would like to extend my sincere gratitude to our mentor, Vaidya Devendra Tribunaji, President, GBRAB, for his continuous support, guidance, and lessons. I thank our director, Dr. Vandana Siroha ma'am, who is the guiding force for all the events at REV. I would also like to thank Vaidya Rajesh Kutecha sir, Secretary, Ministry of Ayush, for his participation and encouragement in all the endeavors. Most importantly, I would like to express heartfelt thanks to all the gurus, shishyas, and other scholars who, with their presence and active participation, make this webinar a successful one. Last but not the least, I thank each member of RAV organizing team who worked behind the stage to make this event successful. Thank you, ma'am. Thank you. Thank you.
Thank you so much.